Hi, welcome to Ophthalmology Test and Discussion, a very powerful tool of instruction as far as I'm concerned, because theory is diffuse and generalized, but questions are very specific. So to answer questions in the examination, you have to know your concepts and also overcome the obliquely placed questions which will be asked to you. Most of the exam questions are not asked directly nowadays. They give you clinical situations or they give you obliquely hints which you should be able to answer. So we are going to discuss 100 questions. I'm going to throw at you 100 questions and expect you to throw the answer back to me. Okay, best of luck. Very well. Let's look at the first question. And the first question seems to be relatively simple. A 3-year-old child comes for suspected squint. A refraction is ordered. What is the drug of choice? And the choice before you is pilocarpine, atropine, tropicamide, and lidocaine. Okay. Now, let's look at the questions. The answer seems to be, to me, to be simple, is going to be atropine. Why is that? Because you see, a child of 3 years old, when suspected squint, remember the most common cause of squint in children is accommodative esotropia, which means the squint is because of uncorrected refractive error. And if you remember your theory, remember children are most often hypermetropic, and this child, 3-year-old, is obvious hypermetrope has not been corrected, and that is why he has developed a squint. So, in order to find out about hypermetropia, what will you do? You will paralyze the accommodative. But because he's a 3-year-old child, so he will require very powerful cycloplegic, which is atropine. Okay, remember, the smaller the children, the more powerful the accommodation. So, therefore, tropicamide really cannot paralyze your refraction, paralyze your ciliary muscles so much that they can reveal your true refraction. And pilocarpine, of course, is a total contraindication. Lidocaine is an anesthetic. So the choice has to be between atropine and tropicamide, and without hesitation, you should answer atropine because it is the most powerful cycloplegic which can paralyze the accommodation of a 3-year-old child, and the latent hypermetropia can be manifested. Let us look at that. See, this is the accommodative esotropia. You can see the child having a right esotropia, left is normal, and this is how they come to use. He's having the squint. So, to find out the cause, we paralyze the accommodative atropine and find that he has hypermetropia. Give him the glasses and look at the squint. This is with correction. We've given the glasses. The same child, you can make out the eyes. This squint has completely disappeared. Okay, so this is the esotropia. The accommodative esotropia because due to uncorrected refractive error, and we give him the glasses by giving atropine refraction and thereby getting him the correct power. So this is without any doubt atropine. Question number 2 is which dye is best utilized for defining corneal erosions and ulcers? Okay, and the choice we have is lissamine green, which is a dye used very nice for detection of dry eyes. Indocyanine green is not a topical dye. Indocyanine green is a dye which we inject into the antecubital vein for fluorescein angiography. So this is not a dye which you can have a topical strip. Rose Bengal is also a wonderful dye for detection of dry eyes. Rose Bengal, but the best answer is fluorescein. Fluorescein stain, kindly remember, is the best for detection of erosions and ulcers. Okay, the bright green color that is evident on a fluorescein staining tells us without fail and detects without any abnormality the ulcers and the erosion. As you can see it here, the bright green of the you can see the bright green of the fluorescein staining. This is the ulcer, and this is the erosion, which you can see the faint stain. This is the erosion, which will detect without any fail. So this is a perfect dye for detecting corneal erosions and ulcers. Very well, that was a simple one that was. Number 3 question, in which examination are the patient's pupils not dilated? This is a standard question, often asked, repeated many times. Let's look at the choice we have. Indirect ophthalmoscopy. Dear me, no. We do need a lot of dilatation for indirect ophthalmoscopy because we need a fully dilated pupil here. So this is out of the question. Retinoscopy, no, because retinoscopy is for calculation of power and we need to dilate the pupil along with the cycloplegia for detection of hypermetropia. Gonioscopy and fundus examination, again fundus examination is ruled out because fundus examination means we need to dilate the pupil to get a better view of the retina. So the best answer here comes to be gonioscopy, and which is absolutely correct. Gonioscopy, you cannot have a dilated pupil. In case the patient is already dilated, then we cannot do gonioscopy that day. Why? Because by dilating the pupil, it artificially pulls the angle wide open, and that would give us a wrong interpretation. So in gonioscopy can only be done in a patient whose pupils are normal. Like this, you may have seen gonioscopy done like this. If a patient is already dilated, then that particular day we cannot perform gonioscopy because it will give us a wrong estimation of the angle. So answer is gonioscopy. Very well. The next question is, what is the commonest cause of loss of vision in diabetic retinopathy? That's the standard question, and let's look at the choices again. Neovascular glaucoma is undoubtedly a cause of loss of vision in diabetic retinopathy. Second is vitreous hemorrhage. Yes, that is true. It's also cause of loss of vision in diabetic retinopathy. Retinal detachment, yes, you do have traction retinal detachment in diabetic retinopathy, but the answer without any confusion has to be C for cystoid macular edema. You see, the most common cause of loss of vision overall in diabetic retinopathy is this problem of cystoid macular edema, so prevalent that we give it a name called diabetic macular edema, DME. It is also called as diabetic macular edema, which stands for DME. And this is by far the most common cause of loss of vision in diabetic retinopathy. You can see the macular edema here. This is the macular edema, which you can see here, though not very clear because you cannot really see this is on a casual inspection. But this is by far the most common cause of loss of vision in diabetic retinopathy, and which you can further confirm by doing fluorescein angiography, which will reveal the famous flower petal appearance. The flower petal appearance, the petaloid appearance, which you can see here. The petaloid appearance or the flower petal appearance, this is done fluorescein angiography, will reveal the famous petaloid or the flower petal of cystoid macular edema. That tells us of cystoid macular edema in diabetic retinopathy. This is the most common cause of loss of vision in diabetic retinopathy. Question number 5 is a 75-year-old lady presents with a 2-year history of a painless, progressively enlarging mass in the central upper lid, distorting the eyelid margin and leading to loss of eyelashes. What is the most likely diagnosis? Let's go over this again. This is not so easy, and the choices are there in front of you. A 75-year-old lady, okay, that's the first thing, an old lady with a 2-year history of a painless, progressively enlarging mass in the central upper lid, distorting the eyelid margin, leading to loss of eyelashes. They seem to be a little tricky, but it's not actually very tricky. Let's look at sebaceous cell carcinoma. Sebaceous cell carcinoma is unlikely to be the answer here because it presents not in the upper lid, it presents mostly in a different location. A squamous cell carcinoma is not a very good answer because squamous cell carcinoma is not a very common presentation of eyelid. Squamous cell carcinoma is the most common carcinoma of the conjunctiva, but not of the eyelid. Basal cell carcinoma and amyloidotic melanoma. Amyloidotic melanoma is again not a very good answer, but the best answer happens to be basal cell carcinoma. Why is that? Because this by far is the most common tumor, malignant tumor of the eyelid. And even though, and look at the age, 75-year-old, it's just the correct age for basal cell carcinoma, even though there is one caveat here that it is the upper lid, whereas basal cell carcinomas are mostly in the lower lid. This is because the most common cause of basal cell carcinoma is UV radiation, ultraviolet light falling, and since the lower lid gets more ultraviolet radiation, so that happens to be the commonest site of the basal cell. But in this case, the 75-year-old lady with a 2-year history, so it's a fairly slow, painless, progressive enlarging mass leads to be the best diagnosis in this case is going to be a basal cell carcinoma, which you can see here with the classic lower lid location here, but that was upper lid just to try to fool you, and you can recognize this by the pearly white formation around the margin. If you look carefully, can you see the pearly white concretion kind of a thing and the central crater? These are the two recognizable features of a basal carcinoma, is the pearly white concretion like material here and a central crater which will make you recognize basal carcinoma from far off. Question number 6 is a question based on anatomy. Let's take a look at that. A retrobulbar anesthetic is least likely to produce anesthesia of which cranial nerve? Remember, when you give a retrobulbar anesthetic, it goes behind the eyeball, that's why retrobulbar. It paralyzes all the nerves, all the ocular motor nerves. which happen to the third, fourth, and sixth. But one particular nerve escapes, or is the most likely to escape, and that is the question: which is the one that is least likely to produce anesthesia of which cranial nerve? And the answer is the fourth nerve. The fourth nerve, you see, the fourth nerve lies outside the cone of muscles. The fourth nerve lies outside the cone of muscles. So when you give a bulb injection, it takes some time for the anesthetic to diffuse outside the cone of muscles and paralyze the fourth nerve. So you will find that the superior oblique is the muscle. Quite often it is still acting under anesthesia. Rest of the muscles are paralyzed because the nerves are gone. But the fourth nerve takes a lot of time, and it's the least likely nerve to get affected by the anesthesia. So the superior oblique is often acting even after a retrobulbar block. It is the fourth nerve. Question number 7 is an interesting question. The main corneal mechanism holding the LASIK flap in place after surgery. You know that after LASIK surgery, there's 3 steps. There's a keratome which cuts the flap. This is under the Bowman's membrane into the stroma, and then you reflect it. The second procedure is the ablation of the cornea stroma by the excimer, and third is you roll the flap back. Okay. Now, after rolling the flap back, remember, we do not need to put sutures. We do not require stitches. Why is that? That's because there is a forceps which seals the LASIK flap in place after surgery. So after surgery, we do not require a flap. It seals perfectly well. And what is that? The choice that we have is the endothelial pump, the stromal collagen adhesions, the Bowman's layer and stromal adhesions, and the endothelial Descemet's membrane forces. The answer is the endothelial pump. Okay. Please remember, this is a theory question which we like to ask you. This is the endothelial pump which keeps the LASIK flap in place. And you've seen the endothelium, it looks like that. Remember, almost 3,000 cells we have. It's a single layer of cells, hexagonal, and there are almost 3,000 cells depending on patient to patient, around 3,000 cells per square millimeter. Remember, each cell has almost 1.5 million endothelial pumps. Okay, this is a figure which you don't have to memorize, just trivia. Each endothelial cell has 1.5 million endothelial pumps. Okay, so these pumps, they give us the force which is essential for keeping the flap in place after LASIK surgery. Question number 8 is a 1-month-old infant presents with a spongy purplish eyelid mass, the most likely diagnosis. This is often used as a spot diagnosis, so you had better tell me this answer immediately. It should not be too difficult. Again, a 1-month-old infant presents with a spongy purplish eyelid mass. The most likely diagnosis, without any question, you should point your fingers to B for capillary hemangiomas. The capillary hemangiomas are the most common tumors of the eyelid in children, and adults may have cavernous hemangiomas, but children mostly have capillary hemangiomas. Rhabdomyosarcoma is not of the eyelid, it's of the orbit, and highly dangerous, highly malignant. Patient dies most of the time. Neurofibromas does not have presentation like this with a purplish spongy mass, and metastatic Ewing's carcinoma, though are not very common but not very unusual either. The best answer is capillary hemangiomas, which is fairly common. See the spongy form and the purplish mass, often seen isolated, or it could be part of the Sturge-Weber syndrome. The Sturge-Weber syndrome, which we have discussed when it causes glaucoma. Very well. So this is a standard, often asked as a spotting question. Question number 9 is the most constant and critical finding in retinitis pigmentosa, and I think you should not have a difficulty in answering this one. The most constant and critical finding in retinitis pigmentosa is A, bone speckle pigmentation retina. Dear me, no, not at all. In many cases, we do not get this pigmentation at all, so this is not one feature you should depend upon. Second, significantly reduced ERG, yes, that is the correct answer. Significantly reduced ERG. Tubular visual fields, yes, though that is, most of the time lands with tubular vision, but other conditions apart from retinitis pigmentosa may also have tubular vision, particularly open angle glaucoma, let's say. Abnormality in rhodopsin gene is not the most important criteria for diagnosis of retinitis pigmentosa. The best answer is a significantly reduced ERG. An electroretinogram is the gold standard for diagnosis of retinitis pigmentosa. You can see that here. See, a normal eye has actually around 2 waves, a negative A wave and a positive B wave. A negative A wave measures the potential difference of the rods and the cones, and the positive B wave measures the potential of the Mueller cells and the bipolar cells. This is how a normal ERG should look. But in retinitis pigmentosa, it becomes flat. Retinitis pigmentosa, it becomes completely flat, and that is the diagnostic hallmark of RP. The most important finding is a flat ERG. The 10th question is, what is true about ophthalmodynamimetry? I don't know how many of you have heard of this investigation, though it's an old time investigation. Let's look what the offerings are. First, it measures the pressure of the ophthalmic artery. B, measures the intraocular pressure of the eye, incorrect, because this is the tonometer, intraocular pressure measured by the tonometer. Measures the velocity of blood flow in the central artery, incorrect. That cannot be done by any ophthalmic instruments, maybe by Doppler, but not by any ophthalmic instrument. And indirectly measures the pulsations of the central retinal vein. Again, incorrect. The best answer, it measures the pressure of the ophthalmic artery. Okay, so this is how it is done. It's an old time investigation. You place the footplate of the instrument on the eye and measure the pressure of the ophthalmic artery, and by extrapolation of the central retinal artery. The next question, ladies and gentlemen, we are going to talk about which of the following is most characteristic of exudative retinal detachments. And that's a good question, and let's focus on that. The first thing is this demarcation lines. That is incorrect, because if you remember your theory, demarcation lines are present in long-standing chronic retinal detachment. These are lines on the retina which tell us of long-standing and chronic retinal detachment. They are not a hallmark of exudative retinal detachment. The second is tobacco dusting. Tobacco dusting is the famous Schaeffer's sign, which is typically seen in rhegmatogenous retinal detachment. This is the only anterior segment finding that you can see with a slit lamp in a patient of rhegmatogenous retinal detachment. What you will see here is, you will see in the vitreous, you will see cells in the vitreous moving up and down like that. They call it tobacco dusting. They are a sign typically of rhegmatogenous retinal detachment. Fixed folds are also not characteristic of exudative retinal detachment. They are mostly seen in tractional retinal detachments. The best answer is the famous shifting fluid. You see, because of the huge amount of fluid that causes separation of the two layers in exudative retinal detachment, this fluid shifts. So when the patient is sitting up, you will find the detachment is inferior because the fluid has shifted down. When the patient is lying down, you will see that the detachment shifts because it goes to the most dependent part, which is the macular area. So often this shifting fluid is the single most important characteristic of the exudative retinal detachment, because the fluid shifts according to the position of the patient. And this is the famous fluid, which, as you can see, is a huge bullous amount of fluid. This is the detached area, the grayish reflex. The red is the normal one. This is the grayish reflex of for exudative retinal, and this will shift as the patient sits up. It becomes more inferiorly. As the patient lies down, the fluid shifts to the most dependent part, which is the macula. So this is the sign. The shifting fluid is the sign of exudative retinal detachment. Question number 12 is, dear me, is an auction is a triad of shaken baby syndrome constitutes of, shaken baby syndrome is when a child gets hit by his own parents. Sadly, too common in our unfortunate country. But this can be diagnosed by the classic triad of a shaken baby syndrome, also called a battered baby syndrome. Let's look at the auction. What's going on here? Choice, it tells us a triad of subdural hemorrhage, retinal hemorrhage, and encephalopathy. B tells us of retinal hemorrhage, vitreous hemorrhage, and hyphema, really bad. C, subarachnoid hemorrhage, vitreous hemorrhage, and intracranial hemorrhage. And the last one is subdural, subarachnoid, and intracerebral hemorrhage. Well, as you can make out, most of you, answer happens to be the subdural hemorrhage is A. Subdural hemorrhage, combination of subdural hemorrhage, retinal hemorrhage, and encephalopathy. Okay, the retinal hemorrhage particularly is what we see as ophthalmologists, because they don't come to us for subdural hemorrhage. Children have delicate, remember, bridging veins, so easily when they hit, they rupture and cause subdural hemorrhage rather than subarachnoid as such. And retinal hemorrhage, which are huge, typically massive retinal hemorrhage, which are so typically seen in shaken baby syndrome. Look at the blotches of hemorrhage. You cannot make a mistake with this. These are not normal retinal hemorrhage. You cannot see them in, let's say, diabetic retinopathy or hypertensive retinopathy. The huge hemorrhages on the retina are a total, it points the finger towards the shaken baby syndrome. So the answer here happens to be A, a combination of subdural hemorrhage because the rupture of the delicate bridging veins under the dural membrane, subretinal hemorrhage, and encephalopathy is question number 12. Number 13 is a question which was asked recently. What is the drug of choice for the patient suffering from HIV and having the following condition as shown in the fundus photograph? Now remember, what is the condition given to us is HIV and having the following condition. So on the retina, you can see this typical yellowish whitish exudation. So characteristically, this tells us that this is CMV retinitis. The most common ocular infection in HIV is, as you all know, is CMV retinitis, cytomegalovirus retinitis. This is a typical description. This is the famous yellowish white exudation, which is often called, if you remember, called the pizza pie appearance. Okay, you can have the pizza pie appearance, also called the crumbled cheese and ketchup appearance, is it not? It's also called the crumbled cheese and tomato ketchup appearance in reference to the red and the white description here. The hemorrhage and is the ketchup and the white exudation is the cheese. Pizza pie appearance. So this is CMV retinitis, and for CMV retinitis, let's look at the drug. Azithromycin incorrect. Azithromycin is used for trachoma in ophthalmology. Trimethoprim incorrect. Valganciclovir is correct. This is now the drug of choice of CMV retinitis because this can be taken as orally. Acyclovir is not utilized anymore in this. So drug of choice answer here is valganciclovir because this is the drug of choice of CMV retinitis in HIV. Should not be a very difficult question for most of you. Number 14 is again a difficult question. All are common HL associations except, okay, that's not so easy to memorize, but let's see what we can do out of this. Choice A is HLB27 ankylosing spondylitis. Yes, absolutely correct. We all know that. HLB27 ankylosing spondylitis is very, very common. Remember, a tall young man, with low back pain, typically they come to us. These are young males with low back pain, with red painful eyes. They come to us, they are ankylosing spondylitis and they develop anti-uveitis. Very correct. HLA29, birdshot retinopathy, yes, is absolutely correct. And please remember, this B, HLA A29, birdshot retinopathy, remember, happens to be the closest relationship between any disease and HLA. This is the closest correlation between any particular HLA. Almost 97% of patients with HLA A29 land up with birdshot retinopathy. This is, kindly remember, a question in which this is the closest relationship between any particular HLA and disease. HLA-B27 is Behçet syndrome. No, dear me, no. Behçet syndrome is typically seen with HLA-B51, and that is why the answer is wrong. And HLA-DR4 is juvenile diabetic mellitus. That's correct. And remember, DR you can memorize as diabetic retinopathy. So juvenile diabetes mellitus is linked with HLA-DR4. That is correct. So the only one incorrect, and that's what the question is asking, except happens to be C, which is not HLA-B7 with Behçet's, but HLA-B51. Answer is C. Question number 15 is the next question. What is asked is, all of them are true in ocular ischemic syndrome except, okay, all of them are true in ocular ischemic syndrome except, again, let's see what the choices offered are. Choice A, it occurs when the carotid artery obstruction reaches 90%, is absolutely correct. Please remember, when the carotid artery obstruction reaches 90%, then there is obstruction of the blood flow to the ophthalmic artery and central retinal artery, and this is when we get ocular ischemic syndrome. That's absolutely correct. Choice B offered to us is a dull pain in the orbital region, a dull kind of pain in the orbital region like this, which worsens on getting up, is absolutely correct. This is a very typical finding. When you're lying down, okay, because of gravity, you still have some blood flowing there, but when you get up in the morning, you're vertical. Because of anti-gravity, the blood becomes even less to the eyes, and the pain worsens in the morning when you get up in the morning. That is also another sign of the ocular ischemic syndrome. So these are both correct. Then delayed recovery of vision following a intense bright light exposure is also seen in ocular ischemic syndrome. When you flash a bright light into the eye, and you will find that typically most of us, we get dazzled, but we recover our vision very quickly. Okay, this is the macular photo stress test, but this is a characteristic of OID, ocular ischemic syndrome, is that when you flash a light, typically it takes more time for the patient to get back to his normal vision. This is also characteristic of ocular syndrome. And the last answer is neovascularization is absolutely incorrect, because neovascularization is a very important sign of ocular disease, which leads to glaucoma often. So this is actually very commonly seen. So this choice D is the answer, because this is incorrect, and that is what we've been asked. All of them are to accept. So neovascular is very commonly seen. The answer is D in question number 15. You can see a photograph of ocular syndrome. Look at the hemorrhages here. The hemorrhages. These are a lot of hemorrhages here, and you can see the dilated veins, the tortuous veins, and the constricted arterioles. The picture is very similar to actually CRVO, central retinal venous occlusion, in the provision of hemorrhages and the dilated tortuosity of the veins and the constriction of the arteries. This is ocular ischemic syndrome. The next question is question number 16, which is asking us that a patient complains of inability in reading a newspaper, particularly in bright sunlight. What is the most likely diagnosis? Okay, so let's look at that. The patient comes over inability reading a newspaper, so which is near vision is affected. Remember, the choices offered to are all of cataracts: nuclear, cortical, posterior subcapsular, and coronary cataracts. So the first thing that is given to us in reading a newspaper, which means near vision is affected, so that makes the answer in favor of a posterior subcapsular cataract. Remember why? Because posterior subcapsular cataracts have loss of near vision. Again, why? Because for near vision, when you accommodate, you converge and constrict. And when the pupils constrict, only the central ray is allowed in, and that is blocked by the posterior subcapsular. So the first sentence itself pushes us towards posterior subcapsular cataract. Let's see what the second thing tells us. He cannot read the newspaper, but particularly in bright sunlight. Does that also point the finger towards posterior subcapsular? Answer is yes, it does. Because you see, first of all, the pupil is already constricted when he is reading because of the triple reaction: accommodation, convergence, and meiosis. On top of that is bright sunlight, so people constrict further. So very little light is coming through, and that also to the center, and which is what the posterior subcapsular is blocking right away, is it not? Very little light is coming. All of it is blocked by the posterior subcapsular cataract, and that is why these patients have difficulty in reading newspaper in bright sunlight. The answer is C for a posterior subcapsular cataract. Why not nuclear cataracts? Nuclear cataracts are more well known for the loss of distance vision. Remember, they are because of the index myopia induced by the nuclear cataracts, they have more problems in distance vision. So they have problems in driving, in watching TV. That's the more important characteristic. Cortical cataracts have more problems for in the night time. Cortical cataract, which is not mentioned here, not in bright sunlight, they have more problems in bright. Why is that? Because in the night time, pupils dilate, is not? Pupils in night pupils will dilate, and as the pupil dilates, what happens? It uncovers the cortical cataract. The cataract is present in the periphery. Remember the cortical cataract. See what happens in night time in a cortical cataract. In the night times, the pupil dilates. Okay, the pupil dilates like this. The pupil dilates, so the rays can go to the periphery, but in the periphery, the cortical cataracts are present. Okay, in the periphery, the cortical cataracts are present, so they get blocked. So they get blocked, and the patient is not able to see at night time. Mostly, cortical cataracts have problems in night vision, so they have a kind of nyctalopia, a kind of night blindness. In the daytime, they can manage fine. Why? Because in the daytime, the pupils constrict. The pupils constrict, so the rays are obliged to pass only through the center, and the center is clear. Remember, it's a cortical cataract. It is a cortical cataract. It is not a nuclear cataract. So, in the daylight, the pupils constrict, so the rays are obliged to pass through the center, which is clear, and so these rays can go focus on the retina. So, they have good vision in the daytime, but not in the night time. They have a kind of night blindness, or at least, if not exactly night blindness, it is difficulty in driving or seeing at night. So these are the characteristics of the thing, and the best answer happens to be posterior subcapsular cataract. Coronary cataract is a cataract like a crown, corona, like a crown, and that is a developmental type of cataract. It's a congenital developmental cataract that has no particular characteristics of this question. The answer is C in this question number 16. As you can see it here, posterior subcapsular cataract. You can see the posterior subcapsular cataract. No, on the, usually posterior subcapsular is got this breadcrumb appearance and sometimes polychromatic luster. So this is the typical flash. This is the anterior part, this is the posterior subcapsular cataract, well known for its glare and loss of near vision. Question number 17, a more difficult question. A 25-year-old lady presents with a unilateral cataract. There is no history of trauma or pain or redness of eyes or steroid usage. What is the likely cause? Okay, so that's a very interesting question. Let's take a look at that. A 25-year-old lady, okay, so that means it cannot be a age-related senile cataract. The most common cataracts is a senile or age-related, which comes to us after 50s. Is it not? So that rules it out. Then it's unilateral cataract, which is also unusual because cataracts are mostly bilateral, okay, because they may be asymmetrical in the sense that the one cataract comes first and the second cataract follows after a few months, but they're usually bilateral, but this is unilateral. Then to compound the problem, there's further. What is that? There's no history of trauma, so there's no traumatic cataract. So this is not a rosette cataract. There's no history of pain or redness of eyes, so it cannot be a complicated cataract because remember uveitis usually has a pain and redness of eyes. Anti-uveitis, this is pain and redness, so that is also ruled out. Nor is there a use of steroid use, which means a steroid-induced cataract or drug-induced cataract is also ruled out. So most of the things that we have in our armamentarium for diagnosing a presenile cataract, a young cataract or a presenile cataract are usually drug-induced cataracts, steroid use mostly likely, or traumatic cataracts or uveitic cataracts. So most of them are ruled out and senile cataract is already ruled out. So what is the best likely answer? Let's take a look at that. The first age-related cataract, which is absolutely incorrect because of the age. Second is a complicated cataract. We just said it cannot be because of the absence of the pain and redness of eyes, which means there is no anterior uveitis before. The diabetic cataract is absolutely incorrect because there is no question of diabetes here, and diabetic cataracts, remember, they are usually posterior subcapsular and there is no history of diabetes mentioned here. The best answer here is C, and what is that? It's a Fuchs heterochromic iridocyclitis. Okay, remember Fuchs heterochromic is a very important differential diagnosis of cataracts in young patients where trauma, steroid and steroid use have been ruled out. Okay, any young patient with a unilateral cataract where trauma and there's no steroid usage, we think of Fuchs heterochromia iridocyclitis. If you remember, this is a condition. Fuchs heterochromia had a classic diagnosis of three features. They had three features. First, you have the heterochromia, which means one iris is lighter colored. This is usually the eye that is affected is the lighter colored eye. Okay, most commonly it is the eye which is affected, which is the lighter colored. Okay, second is cataract, and third is glaucoma. Okay, so this is the classic triad of FHI, also called Fuchs heterochromic iridocyclitis. They come to us. You see, this is a kind of uveitis, but it's a very unusual uveitis in the sense that there is no pain or redness. The patient is never aware of any pain or redness or loss of vision, so it never comes to you. It only comes to his attention when he develops the cataract, the complicated cataract. Okay, this cataract is well known for its absence of posterior synechiae. Okay, most complicated cataracts would have some posterior synechiae, but remember the cataract of Fuchs heterochromic iridocyclitis does not have any posterior synechiae. Okay, so this patient is not aware that there is some uveitis going on in his eye because there is no pain, no redness. So why does he come to us? He comes to us months later when the cataract develops and there is loss of vision. Then he comes to us, and on examination, what we find is a completely white eye. There is no redness, no pain. The only loss of vision is because of the cataract, and the iris is heterochromic. So we find that there is a heterochromia. That iris, that gives a clue. A lot of times they have glaucoma also, but it is the cataract in a heterochromia which gives us a clue. Also, a very important thing is the typical KPs distribution. Because the uveitis, you have keratic precipitated, but remember these keratic KPs, unlike the other KPs, are not distributed in the Arles triangle. They are not present in the Arles triangle like this. They are diffusely, most KPs in uveitis are present in the Arles triangle. But Fuchs heterochromic is unique because its KPs are diffuse all over the endothelium. They are plastered. They are not restricted only to the Arles triangle. So we see this diffuse endothelial KPs, we see the cataract, we see the heterochromia, and a diagnosis is complete. This is the typical Fuchs heterochromic iridocyclitis and it presents to us like this. As you can see, it's a white eye, It's completely white eye. There's no redness. But you can also see the cataract here, which the patient presents to us. And though you cannot see this in this picture, there's usually diffuse KPs, which tells us about the heterochroma. You can see the iris is lighter colored, though I haven't got the other eye for comparison. But this is a lighter colored heterochromic eye of the FHI. That is a very interesting question. Question number 18, more difficult ones coming up. Minor cylinder lenses are prescribed because of, you know or should know that mostly we prescribe minor cylinder lenses, not plus cylinder, though we can transpose them, but we prefer to prescribe cylinders in minus form in spectacles. Okay, but why? Is it because it's cheaper to produce and distribute? Number one. Is it preferred due to the meridional anisoconia? Number three. Is it because it reduces minification? And is it because it causes less coma in trefoil? Okay, these are higher order aberrations. Okay, these are higher order aberrations. So these are the four choices we have, and the answer here is B, which is preferred due to meridional anisoconia. See, first of all, we need to know what is a minor cylinder and what is a plus cylinder. You see, we can prescribe in either form and transpose them. If you remember our refraction classes, suppose I have a prescription like a -3 diopter sphere with a -2 cylinder at 90 degree, right? Now, as you can make out, this is an example of a compound, myopic, regular astigmatism, which happens to be against the rule. It's minus at 90, so it's not with the rule, it's against rule astigmatism. So, the entire diagnosis is compound, myopic, regular, against the rule astigmatism. Okay. Now, this is a minor cylinder form. You can see in this form, this thing. Now, I can convert this into a plus cylinder form also by transposing them. You remember the rules of transposition? First rule, number one. Let's do this again. See if you can remember the 3 rules of transposition. Okay. Transposition, remember, transposition means that you change the prescription to a mirror image. Okay. Mirror image. Okay. So, you suppose I place the prescription in front of the mirror. How will this prescription look? You know, if I stand in front of the mirror, okay, I get inverted. My left becomes right, right becomes left, but I'm still me, isn't it? I don't become Greta Garbo or King Kong or something like that. So, therefore, the prescription remains the same, but when it's placed in front of the mirror, it looks different. And let's look at the rule. The first rule, if you remember, is to change the sign of the cylinder. Okay, if it's minus, change to plus. If it's plus, it change to minus. So, first rule is to change the sign of the cylinder. So, I make it from minus, it becomes plus 2 cylinder. Okay. The second rule is to change the axis by 90 degree. Okay, change the axis by 90. So, if it's 90, it becomes 180 degree. Okay. So, remember there are 3 rules. Change the first, I change the sign, change the axis by 90 degree. So, it was 90, it was 180. And the third rule is an algebraic summation. Algebraic summation of the sphere and cylinder. So, algebraic summation means keeping the signs intact. So, -3 with -2 becomes -5. So, this is the new prescription that we have here. This is the new prescription. This is the new prescription. Remember, these are transposed. Okay, again. So, the final prescription happens to be now -5 diopter sphere with a +2 cylinder at 180 degree. See, they are transposed. That means this and this are the same prescription. Remember, transposition means the same prescription. So, the patient will read 6/6 with this prescription and 6/6 with that prescription also. But he will be more comfortable with the minor cylinder. That is what the question is. Okay, so there's a plus cylinder, there's a minor cylinder form. You can have either one. Both of them will give 6/6 vision because they are the same prescription. Remember, they are transposed images in front of a mirror. But they'll always be more comfortable with the minor cylinder. That is why we write them in the minor cylinder form. In fact, even if you write in a plus cylinder form, you know what will happen? Even if you write in a plus cylinder form, the chemist will, not the chemist, beg your pardon, the optometrist or the optician will convert this, will transpose them into the minor cylinder form and prescribe them, just because the patient is more comfortable. But that is the question. Why is the patient more comfortable with the minor cylinder? Okay, and the answer I told you is of a meridional anisoconia. What is that? See, first of all, you must have some basic idea. What does it mean to have a minus or a plus cylinder? Can you remember, a plus cylinder is ground on the anterior surface of the spectacle and a minus cylinder is ground on the posterior surface. You understand what I mean? You have to grind lenses. You have to grind lenses to make a cylinder or a sphere. So again, to summarize, again to repeat, the plus cylinder form, the cylinder is ground on the anterior surface, and a minus cylinder is ground on the posterior surface of the lens. Let's see if we can make this clearer. You can see this here. This is a lens, but you can see the plus cylinder is on the place. It is the anterior surface of the lens, and the minus cylinder is ground on the posterior surface of the lens. Is it not? So if it is the plus cylinder, you can see the anterior surface is the cylindrical form. So obviously this will cause more scattering and diffusion and distortion, is it not? But if it's in the posterior surface of the lens, then the anterior surface of the lens does not have the cylinder. It's a part of a sphere, so it will scatter light and transmit light with equal felicity. But because plus cylinders, the cylinder is ground on the anterior surface of the lens, so the light will hit the anterior surface, which is cylinder, and cause more distortion. This is called meridional anisoconia, and that is why it's been always known, a well-known fact, that cylinders are prescribed in a minus form. You can write in either form, but finally it is transposed to a minus form because the patients are more comfortable. Question number 19. Which of them are the second order neurons, are called the second order neurons? That's a question often repeated again and again. So kindly remember, we have these four things: rods and cones, bipolars, ganglion cells, and geniculocalcarine neurons. Please remember, the human visual system is a four order neurons. Is four order neurons. Okay. What is that? The first of all, the first order neurons are the photoreceptors. Why? The rods and the cones. Because the light comes and strikes the rods and the cones first. So it activates the rods and the cones. That's the first order neuron. And then the rods and cones transmit this information to the second order neuron, which is the bipolar cells. Then the bipolar cells transmit this information to the third order neuron, which is the ganglion cells. And finally, the ganglion cells transmit information to the fourth order neurons, which are the geniculocalcarine. They are called geniculocalcarine because they are located in the lateral geniculate body, and from there it projects information to the cortex where the calcarine fissure lies. So these are the four order neurons of the human visual system. The first order, I have given the choices in the order that they are actually there in the eye. The first order, the photoreceptors, rods and cones. Second order are the bipolar cells. Third order are the ganglion cells. And fourth order is the geniculocalcarine neurons in the lateral geniculate body. You can see it in this picture. The first order, rods and the cones, here it comes. Okay, photon writes photopigment. And the second order is the bipolar cell here, which transmits it to the third order, which is the ganglion cell. And the ganglion cell transmits information. The fourth order is sent to the brain via the geniculocalcarine neurons. That's the fourth order. Okay. So the question was asked, we were asked, what is the second order? Is the bipolar cells, which is number B. Bipolar cells, if you remember also, they give us the B wave of the ERG. Bipolar cells contribute majorly to the potential difference recorded by the ERG. The B wave, B for bipolars, can you remember, B wave, B for bipolar cells is because of the potential difference in the bipolar cells of the retina. Question number 19 is B. Question number 20. Well, let's look at the question number 20. 20 is the earliest sign of papilledema. Okay, remember, papilledema is disc edema due to raised intracranial tension, is not? It's disc edema to raised intracranial tension. So you will have disc edema because of the backflow of the exoplasm. And let's look at what is happening. Is enlargement of the blind spot. We know it's a very common visual field defect of papilledema, but this is not and cannot be a sign of papilledema. Choice B is a loss of venous pulsations. This is correct. This does happen in papilledema. Remember that in the optic disc we have spontaneous venous pulsation. Remember that, no? Remember, there are only two veins in the body. There are only two veins in the body which have spontaneous venous pulsations. One is the jugular pulse, and second is the venous pulsation of the optic disc. The rest of them you have arterial pulsations. So in papilledema you do have loss of venous pulsations. That is correct. Then choice C is the blurring of the nasal margin of optic disc. This happens and because disc edema will occur, so you will have a blurring of disc margin and it is nasal margin. This is also correct. And abnormal pupil reactions, remember, abnormal pupil reactions do not occur in papilledema. Papilledema, the pupil reactions are absolutely normal, which is what makes it difficult for us to diagnose. in papilledema, the pupils are absolutely normal. So the choices like B and C. The question is asked, what is the earliest sign? Can remember the earliest sign is the blurring of the nasal margin of the optic disc. Choice C is the correct answer. And you can see it here. This is the blurring of the disc margin. You can see normally the optic should be clear. You could clearly make out the distinct difference between the disc and the retina. But here, if you look at what's happening, there is blurring of the disc margin. The disc margins are so blurred that you cannot make out where is the disc ending and where is the retina beginning. So the answer is the earliest sign of papilledema, particularly the nasal margin of the disc, is the first to get affected.